Cinta jadi kebanggaan Indonesia, pelopor pengembangan pengetahuan, inovasi, adaptif kolaborasi.
Kita mencintai Unair, hati kan empati, pusat pendidikan terkemuka, world class medicine faculty. Fakultas kedokteran Unair tercinta, jiwa wirausaha, akhlak mulia, profesional, responsif, inovatif, modern dan bangun entrepreneur. Kita mencintai Unair, hati kan empati, tanggung jawab, disiplinkan diri, the prime medicine faculty. Kita Unair, kita mencintai Unair, hati kan empati, tanggung jawab, disiplinkan diri, the prime medicine faculty.
Ya, gue
Medicine faculty.
Oh ja, dankjewel.
Fakultas kedokteran Unair tercinta jadi kebanggaan Indonesia, pelopor pengembangan pengetahuan, inovasi, adaptif kolaborasi.
Kita mencintai Unair, hati kan empati, pusat pendidikan terkemuka, world class medicine faculty. Fakultas kedokteran Unair tercinta, jiwa wirausaha, akhlak mulia, profesional, responsif, inovatif, modern dan bangun entrepreneur. Kita mencintai Unair, hati kan empati, tanggung jawab, disiplinkan diri, the prime medicine faculty. Kita Unair,
Good afternoon, ladies and gentlemen. Welcome to the 61st Airlangga webinar conference series with the topic of how to conduct research in the pandemic era, technical aspects and opportunities. My name is Rahul, along with my senior, Dr. Ahmad Haryana, and my colleague, Wina, Kevin, and Arya. We are the organizing committee members of the afternoon's webinar. This webinar is organized by the Faculty of Medicine, Universitas Airlangga, Surabaya. We are happy to announce you that up until now, the registrants have reached 284 registrants. Before we proceed to the main event, we will announce some of the rules regarding the certification and question and answer session of this webinar. Rules for certification. Participation during the webinar is required. Your attendance will be recorded by the Zoom application. By the end of this webinar, participants are required to fill a questionnaire which the committee will send the link of in the chat box. The certificate will be sent to your registered email address. Rules for question and answer. Please use the question and answer box on the middle of your Zoom panel to write down your questions. Questions will be sorted and discussed after all lectures have been presented. Thank you, Arya. Thank you, Arya. Thank you all for your participation, and we sincerely hope you enjoy this webinar. We will start this event with an opening remark from our beloved host, Kartika Afrida Fauzia, medical doctor. For Dr. Kartika, the time is yours.
Good afternoon, ladies and gentlemen. Welcome to the 60th Airlangga Webinar Conference Series 2021. So first of all, allow me to extend my warmest welcome to all of you to this webinar about how to conducting study in the pandemic era, technical aspect and opportunities, hosted by Department of Public Health and Preventive Medicine, Faculty of Medicine, Universitas Airlangga. So I'm Kartika Frida, will be the host for today's webinar. And so since March 2020, World Health Organization already decided that the COVID-19 infection is a pandemic. So currently, because of the social mobility is restricted, organizing research is a challenge. So researchers need another skill to conquer the situation and still be able to reach the target as it should be. Therefore, we need, this program will talk about how to tackle that challenge and in the technical aspect and also in the statistical aspect, because statistics is also an integral aspect in the quantitative research. So this meeting will be practical and interactive with plenty of time for discussion. So Dr. Samtrianingsih Handayani, Magister Kesehatan, Magister of Science, PhD from Department of Public Health and Preventive Medicine, Universitas Airlangga, will be our moderator today. To guide the valuable lecture from our honorable speakers, Professor Nico Nagelkerke, Magister of Science, PhD, a Professor of Biostatistics in United Arab Emirates University Al Ain, and also Dr. Puji Lestari, Magister Kesehatan from Department of Public Health and Preventive Medicine, Universitas Airlangga. Continue with discussion with our panelists, Dr. Muhammad Miftahul Surur, Dr. Magister Kesehatan, Spesialis Penyakit Dalam, Konsultan Gastroenterologi, PhD, Vice Rector of Internalization, Digitalization, and Information, Universitas Airlangga. And also Dr. Pirlina Umiastuti, Dean Pop Magister Kesehatan, Lecturer of Department of Public Health and Preventive Medicine, Faculty of Medicine, Universitas Airlangga. So before we start, let's take a moment to sing Indonesia Raya and also Himna Airlangga for the committee time.
Indonesia bersatu.
Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah badannya untuk Indonesia Raya. Indonesia Raya, merdeka, merdeka, tanahku, negeriku yang tercinta. Indonesia Raya, merdeka, merdeka, hiduplah Indonesia Raya. Indonesia Raya, merdeka, merdeka, tanahku, negeriku yang tercinta. Indonesia Raya, merdeka, merdeka, hiduplah Indonesia
Thank you, ladies and gentlemen. Now let's proceed to our main agenda for today. So first, I would like to briefly introduce our moderator for today's webinar, Dr. Samtrianingsih Handayani, Magister Kesehatan, Magister Education, and PhD. She graduated the medical study from Airlangga University and also graduated from Monash University for master degree in in education system, and also Illinois University, USA, for the PhD in health policy. Currently, she is our proud lecturer in Department of Public Health and Preventive Medicine, Faculty of Medicine, Universitas Airlangga. Now, I will hand over the session to Dr. Samsrianingsih Handayani, Dr. Magister Kesehatan, Magister Education, PhD. The time is yours.
Thank you, Dr. Kartika. She's from Erin from Japan, I think. Thank you. Good afternoon, professors, doctors, students, ladies and gentlemen. In a few moments, our distinguished speakers will be presenting two topics. The first topic will be conducting research in the pandemic era, lesson learned from the global expert. And the second topic will be how to conduct secondary data research. Our first speaker is Professor Nicholas Jan Dirk Nagelgerke, I'm sorry, Master of Science, Doctor of Philosophy, a worldwide renowned biostatistician, epidemiologist, and also mathematical modeler with an enormous work on infectious disease, epidemiological research and modeling, especially in the area of tuberculosis and HIV/AIDS. Professor Nagelgerke is affiliated with the United Arab Emirates University, as Dr. Kartia says, and has a long history of cross-country research and teaching work that one PowerPoint slide would not be shown with. And without further ado, please welcome Professor Nagelgerke. Professor Nagelgerke, you have 30 minutes. Thank you. Please unmute your, yeah, thank you.
Okay, then let me go to my share screen. And I think this is fine, yes. Okay, one of the most striking differences between this pandemic and the ones I've followed for 40 years now, the HIV, is the rapidity of the scientific response. With HIV, it took many years before they discovered the virus, they've developed tests, etc. And this has all been very, very, very much accelerated. Within weeks, the sequence of the virus was known, tests are available, vaccines are now coming upstream, and many different ones, whereas for HIV, we don't have a vaccine yet. And this, of course, offers also lots of opportunities. Although the pandemic, of course, is a disaster, it is a great opportunity to do research. And I just go through a few and then discuss this in the context of a public health department. Well, of course, the virus and viral mutations, I think this is a big area of research, but I think the public health department are usually not involved in this, although they could be more because it's very close to statistics, and there could be collaborations with bioinformatics departments. For instance, the spread of new variants, etc. So try to link up with departments that the virology and bioinformatics departments and see how you can collaborate. Then, of course, there is this viral host interactions and immune responses. Again, it's the same, that here I see a role for collaboration between public health and, for instance, virology or pathology, and in order to work together. And the same, and for the tests, PCR, antigen tests, and antibody tests, of course, here there is a much greater role for public health departments because tests are things that are used in practice. How can they be used? What are their qualities, their sensitivity, their specificity, in what populations, etc., etc. Again, clinical studies is also a very good area for collaboration because of the public health department, usually the department with the best knowledge of epidemiology and statistics. And that is where a great deal of input is needed in the clinic, because they collect data, but very often do not really understand how to analyze it, how to go forward with it, etc. And the same for interventions and therapies in the clinic. Then you come much more into your own in epidemiological studies. Who is infecting whom? And that is very important in the context of measures that you want to take. So far, governments have been struggling to find appropriate interventions. They have limited, they have closed shops, etc., without any evidence that this is effective or that it reduces a lot of transmission. And I think here, the role of a public health department is very essential. And then, of course, you get to public health itself. What can reduce transmission and how can we do monitoring and surveillance? What is going on? What is the actual status of the pandemic in the different parts of Indonesia? Down. As I said, the public health department can be involved in all types of research, and you can initiate the research yourself independently, or you can seek collaboration with other departments, fundamental research, and your role can then be to provide statistical analysis services, epidemiological services, ideas for research in the field, etc. And of course, you can look around what governments, ministries want, what kind of money is available for what type of research, etc. And then try to develop protocols to respond to this. And that is also a good way of doing very relevant studies. Okay, one of the things is you can do, for instance, is independently, is to look at how do household structures affect virus transmission. Have households with children, are the parents more at risk than households without children, for instance? So, which would be an indication that children are the ones who bring in the infection into the household, and do multi-generational families, what is the role of transmission of children to grandparents and who are at risk of serious infection, etc. Another thing is how to study how do Indonesians respond to public health, for instance, social distancing messages. What we see in lots of countries is that initially the first 2 months, people responded very well. They distanced, they were afraid of other people and avoided them. But by now people are fed up and they just try to avoid all kinds of social distancing and try to get together even if it's illegal. And then very, very important is how many people have become ill, how many have become infected, and how many have died. In a lot of countries, people try to measure the infection fatality rate, which differs very much between countries. In some countries, at above 1%, and in other countries, it's substantially below 1%. And one of the factors, of course, is the age structure of the population. And then I think this links with the secondary data talk is you can do research driven by available data. If you find out that there is some mortality data, you can try to get hold of it and try to analyze it and see how what conclusions you can draw from it relevant for the pandemic. Then you can see where are people getting tested, and you can try to contact them and see whether it's possible to interview clients to get some more information than they collect, because they are just there to collect to take tests, but you want to know why are they getting tested, who pays for it, etc., etc. And then you can try to look for clinical data from hospitals and other facilities. And the big art is to combine the two approaches to see how data, available data, and questions that you have can be combined and to make to write useful papers and give useful recommendations about the pandemic. Now, the infection fatality rate in Indonesia, how much is it? And as I said, the big difference between different countries. In Spain, it's about 1%, but in China, it's only about 0.6%. And in Doha, in Qatar, it was just about 0.2%, where there are very few elderly people, of course, which greatly affects the infection fatality rate. But how much is it in Indonesia, and are there differences between the different parts in Indonesia? And what do you need? Of course, you need two things. First is how many people have died, and how many people have become infected. And both are not so easy to measure. The number of died from COVID-19 is hard to estimate exactly. In Europe and in North America, there are cause of death registrations, but they are usually not very accurate. The number reported as COVID death is also an underestimate of the real number. And the only number that is more or less reliable is excess mortality. So how many more people died than they expected if there wasn't an epidemic, a pandemic. A very interesting study I saw was from Jakarta, that is in one of those archives, and this was a very clever trick that someone used. Apparently, it is to bury a person, you need a permit, and he looked at the number of permits, or he or she, I don't know, looked at the number of permits that were applied for or were given, and compared this to the number in the previous 5 years. And it's a very interesting pattern. What you see is that there is a big rise where everyone knows that the pandemic really took off about 1 year ago, end of February, early March of 2020. And then it wobbled a bit, and then you can also see a second peak around early September. And just by looking at available data, he made a very interesting estimate of the overestimate of the excess mortality that occurred due to COVID-19. And you can even express it in a percentage. You can see it's about a third to a half more than normal, which is pretty substantial. And which suggests, by the way, that a lot of people must have been infected already, much more than in North America or in Europe. Otherwise, this kind of excess mortality would not have occurred. But we don't know, of course. In order to, okay, let's first talk about this mortality. What you want to know, of course, is also more details about who died. And what age group, is there a certain male and female difference? And are there specific areas that are more affected? And then very interesting is, if you look at the peaks, you wonder what caused the different waves in the curve. Is it related to public health measures? What exactly went on? School holidays are, of course, very important. There's a much better understanding now that schools play a major role in transmission of COVID-19. Even though children don't get ill very much, they do transmit the infection between households. There's the easy transmission within household, but from between households, the children who meet each other in schools play an essential role in Europe, but is this the same in Indonesia? That I don't know. And then, of course, you want to compare different parts of Java or different parts of Indonesia, dependent how easy it is to travel and how easy it is to get contacts, etc. And then the next question, of course, is how many people have cumulatively been infected? And the only way to answer it is by serological data. Interviewing people, how many people have fallen ill, is not very reliable, but many people got, a cold or a flu for other reasons, and there are lots of people who were infected who never developed any symptoms or didn't really fall ill. And perhaps, I don't know whether this is used already, but in some countries they do either special surveys, serological surveys, or they use blood transfusion services where people collect blood anyway to test whether there are antibodies in the blood of donors. And this is a way of trying to estimate the percentage of people who already got into contact with the virus. And I think that it would be an easy opportunity to measure this in Indonesia. There, of course, it's blood transfusion service. I think there are two in Indonesia. There are the Red Cross services and their governmental services. And it depends on how easy it is to contact them and to persuade them to add some extra tests. Usually, blood transfusion service already test for lots of infections like HIV, etc., to make the blood supply safe. And it would be very easy to include another test, antibodies against COVID-19, SARS-CoV-2, in order to get an estimate of how many people got infected already. It's not fully representative because, of course, children are underrepresented and also elderly people tend to be underrepresented. But the fact that it's easy and also that it's continuous because you can repeat it every week or every 2 weeks or whenever you want is very important. And it's also a very good tool for surveillance. What is really going on in the population? You can, of course, do your own dedicated study, but that's usually a one-off thing. And because you have to follow survey design methods, multi-stage sampling, etc. And that usually takes both time and it's also very complex and therefore costly, as Indonesia is huge and even Java is a big place. So that would be difficult to do. Better to look for opportunities, places where people already collect blood and try to add on serological testing. Then you can do some studies at testing sites, going to places where people get PCR tested or rapid antigen testing. And you can ask those centers whether you are allowed to interview participants, and then you ask them, why are you getting tested? What is the result? And perhaps you can record their mobile phone number. And I suppose that most people have mobile phones, and then you can try to follow up whether they fell ill, what happened to them, whether they went in quarantine, etc., etc. And that offers a very easy opportunity to do your own research without spending a lot of money. Of course, what you need is a lot of diplomatic skills, a big smile when you contact testing centers and try to ask them to collaborate. Clinical studies, of course, are very important. I've had several requests from clinical researchers to help analyze data on disease progression. People get hospitalized, and very often they don't know when people get hospitalized, which is also already a minority of all patients, of course, is they don't know who is going to develop severe disease, need intensive care, intubation, who is going to die, and why. And understanding this at an earlier stage is very important because it may help you to decide who needs hospitalization or who can safely be treated outside of hospital. And then we have, you can do all kinds of interventions. People come up with lots and lots of different kind of potential treatments. You mentioned chloroquine, ivermectin, and azithromycin, and lots of other potential treatments. And it's very important to study them in Indonesia, where the patients may be a bit different from other places, and also to see what combination of treatments work best, and which patients respond better than others. And this is where your expertise would be very, very welcome, because there's always a shortage of good statistical and epidemiological knowledge in clinics. And you can organize the studies in clinics in different ways. For instance, the classical randomized clinical trials, but what you could also consider is what they call Zellen designs, where you do not really do a clinical trial, but you take a sample of eligible patients, and then you ask only those patients whether they are willing to participate and receive a new experimental treatment. And there are a lot of this of literature on this, so let me not go into it, but it's much easier and faster to do than the the standardized randomized clinical trials. And they are just as valid. And then you have the post-discharge follow-up. What happens to people after they have been discharged? How fast do they really recover? How fast can they go back to work, etc., etc.? All very important questions. Another point that is usually ignored because it's sensitive in clinic is nosocomial transmission. Both the SARS, the first SARS and the MERS epidemic were really nosocomial epidemics. For instance, MERS, which was not very transmissible, caused only a pandemic or an epidemic in South Korea, where the hospital hygiene was not very good, and different patients and hospital workers got infected. And of course, clinics don't like this because they are afraid that patients avoid the clinics, but that's very important to study because it may help you to avoid this kind of transmission. And what often happens is that patients are not recognized as COVID patients. They infect other patients in the ward, also healthcare workers, and the healthcare workers, if they don't develop symptoms, they transmit to other patients, etc. And since those patients are usually at risk, they tend to be elderly and already have other infections, they are at risk of developing serious disease. And this had often been swept under the rug, but now gradually papers appear on how this happens and how frequently this happens. And one of the things, for instance, is that the big epidemic in Lombardy, in northern Italy, was to a large extent really a nosocomial event. Lots of transmission within the hospitals and the clinics. Then you can easily study transmission within households. You can study transmission in workplaces, and of course, important in Indonesia, what is the role of air conditioning and aerosols in transmission? Are air conditioning equipment, are they responsible for transmitting the infection between different rooms, different wards, etc.? Of very great interest are super spreading events where one person infects many others, which can occur during indoor mass meetings, for instance, etc. One difficulty, of course, is you may need collaboration with virology department because you have to prove that they all belong to the same cluster, that there is transmission between different cases, which is usually requires some sequencing. And even then, what is difficult is to identify the directionality of transmission, who has infected whom. And that can be complicated because even with molecular methods, you cannot demonstrate when A and B fall ill and they belong to the same cluster. So transmission has occurred whether A has infected B or B infected A, although timing can of course be a big help in doing this. And this is, for instance, you have different 5 cases, and there are lots of different ways that people could have that a cluster of 5, that how different transmission trees are consistent with a cluster of 5. You could have that, that one N1 infected T1 and N2, and then N2 infected T2 and T3, but there are lots of other possibilities. And to distinguish them is not easy and a topic of current research. Then let me skip this. This is an example of a study in London where they looked at transmission within a hospital. Then how to study nosocomial transmission, and that is first, of course, you have to gain the trust from hospitals, etc., and you have to try to see, to follow up people after they were discharged from hospital for other reasons and see whether they are at risk of developing COVID disease. You can look at other at the staff and whether they, with whom they were in contact with. You can look at virological sequences, etc. So it depends on the of what kind of data are available. But it is important to study this because I'm sure that Indonesia, being such a large country, the level of preventive measures and hygiene must differ very much among healthcare facilities, with some of them very high quality and others much more sloppy and easygoing. Another area where you could make a contribution is developing mathematical models. And mathematical models are a great help in understanding what goes on and are also a good reason to do specific research to find out how, what are the context structures, etc. So I think, I don't know whether you're already working on them, but I think developing some expertise otherwise is very useful. Yeah, and you can try to use it also as a tool to study the impact of measures on actual behavior. You can study real transmission risk using such a model, and economic side effects can also be included. Important, of course, is the time horizon. Do you want to look at the next 2 months or the next 2 years, etc. You can all make the decision yourself. And then you can try to see whether your model is able to address strategic issues for who should be vaccinated first, etc., which is a big issue when there is a shortage. Most models are based on those respiratory models are of the simple SIR structure. People are initially susceptible, they become infected, and then they become removed. And by removed, it's usually assumed that they are immune, which is not always the case because people can lose immunity or be susceptible to different strains. So this adds already complications. And for realism of this, of course, you have to add age structures, loss of immunity, social contact structures, interventions, etc. So this quickly complicates the making of a model, but it's very important to get an understanding of what goes on and can be a good driver for doing empirical epidemiological research. What usually happens if you do the simple model is that you see a very rapid decline of people who are susceptible. You see a short peak of people who are infected and then a rise of the removed and immune. And that usually if you put in the standard parameters of COVID, this all takes place within 3 months or so, which is not very realistic because we see that even after a year, we are still struggling with the pandemic. How, in fact, to observe the different compartments, that's also not very easy. Susceptibles are people without antibody. Well, in principle, we can measure that. But how many people are infectious, that's already difficult because the people who get tested are usually not representative of the population. And representative studies, continuous monitoring of the percentage of people who are infectious, who are PCR positive, are simply not done and are difficult to do. And the number of people with antibodies, that can be studied, but reinfection can occur and loss of immunity over time can also. And of interest, of course, if you look at the curve above, the sharp peak in the number of infections, you see it differs very much from the mortality curve in Jakarta, where we see much more wobbly, stretched out curve over many months. And what the question you may ask is, why is it so different from a simple model? What happened? Is it due to interventions? Is it due to social distancing? Is it a matter of heterogeneity? So there are many small epidemics with different time lags in between. These are all issues that you can try to address, partly in the office, reading available data, but partly also by going out and collecting data. And as I said, mathematical models are important, but a good model takes time in the sense of several months, but it's a great learning experience. And models can be very influential, and I think sometimes they're too influential because policymakers often don't understand the weaknesses, and predictions have not always been very good, and heterogeneities in behavior have often been ignored, which are maybe the cause of poor predictions, and the empirical basis is sometimes a little bit thin, and the weaknesses in the model in countries where they have been used are not very transparent, and modelers have been afraid of being open about what they assumed and what they really knew, and that is unfortunate. I think openness and transparency is important. Then we get to operate. I think I'm through my time more or less. Okay, then operations research is also something you can do in public health department. How do you do planning of testing, data management, staff allocation, and then overcoming administrative bottleneck? And my key message is actually try to be opportunistic. Think about time. How long will it take to do a certain study? If it takes years, then it's useless. So time is a key important, and have a keen eye for low-hanging fruits. If you see an opportunity, grab it. That's basically my message. And I would like to say terima kasih to all of you, and thank you for inviting me.
Danke, Professor Nagelkerke. Very nice presentation. Open our opportunities for us. And now let's move to the second speaker, Dr. Puji Lestari, Magister Kesehatan. She is affiliated to the Department of Public Health and Preventive Medicine, Faculty of Medicine, Universitas Airlangga. She earned her degree, medical degree, and then master's degree in public health, and also Doctor of Philosophy from Universitas Airlangga. And then she went to United Arab Emirates University to meet Professor Nagelkerke to be his supervisee there. She got a fellowship to United Arab Emirates. So here is the topic, doing research on secondary data. Dr. Puji Lestari, thank you. Please present it in 30 minutes. Thank you.
Okay, thank you for nice introduction, Dr. Sam. Good afternoon, everyone. So here we are. In our lifetime, we have experienced going through the pandemic. Yeah, it's obviously devastating, especially to whom losing the loved one. But as a humanity, we'll survive. We have to still going on with our agenda, especially our research agenda. So today is one of the alternative to do the research in pandemic era. It's with the secondary data. I will share my ideas and some experience about it. I think I will talk more general than Professor Nico before, because Professor Nico may be more focused on how we use the COVID era to do the research and what our opportunity here. I will more to technical aspect on secondary data and what our opportunity to do that. So first, I would like to make the same perception among us about what is the secondary data research. Oops, sorry. Yeah. So the secondary data is by definition is we involve the use of data that's already collected by somebody else in the past. So with primary research, we do collect by ourselves. And the type of data, of course, because it's done by somebody else in the past, is past data. But with primary, we do with our own, it's called real-time data. And conducted by ourselves in primary research, but in secondary, it's conducted by somebody else. So for primary research, we can customize our needs to collect the data. So the data, of course, address specific need of our research but in secondary, it may not directly address or may not the same scale or the same format or the same categorize as our needs. And involvement in primary, you do involve, but in secondary, you less involve. But the time is short here in secondary. In primary, you do need time to complete it, all the preparation to collect the data. And the cost, of course, some web offer the free access. Yeah, so it's for the same amount of a sample, it could be lower than the primary one. Okay. So where the source to look at? There's maybe so many here, but I will just suggest you some, which can I provide the detail, but it's not all. I mean, it's not, you don't have to be constrained by this option, but you can have your own secondary data. Just you can Googling it, and even we can do the word scale research or the regional research with the data available. But of course, I will focusing on Indonesian research. Yeah. So we can use, of course, hospital or clinic medical record or clinic administration data, like how many people visit, what the reason they visit, when they visit, something like that. And then, yeah, this one, one big one is a health minister organized survey by Balitbangkes. Yeah, and then Indonesian Family Life Survey. This one is longitudinal. So it's very nice to look at. And then Statistic Bureau, Bureau Pusat Statistik, meteorology and geophysical data, the climate data, yeah, the weather data. And social insurance, PCare, BPJS is already open for some recent years. And Dollar State and Gapminder will be the one I will show you. It's interesting, organized by Anna Rosling, I believe. Yeah. And of course, you can download some map from Google Map or download some density of health facility or others in Google. And of course, YouTube is also one sources that you can do also depending on your research questions. Yeah, for medical record and administrative data, you need ethical clearance. Yeah, and it's access usually with approval or mostly with approval of doctors are directly involved in the care and treatment of the patient. So you need permitted and you need to involve the doctor over there. And demography data, you can compare demography data, making a cross-step demography data and clinical data. You can also see the length of treatment, time to complication, time to death, and also combined with primary follow-up. I think we can refer to our webinar 22 webinar, challenge research publication. This may be some of a presentation already discussing about this. Sorry. So for the survey kesehatan for Minister Health survey here, there is from they held it since 1972, and then they do regularly, but it is not necessarily the same method or necessarily the same operational definition of the subjects. Sometimes they do changes something. Yeah, so you need to see also the manual book or what their definition about some disease or some some people with the risk. Yeah, so there is maybe it's already available in now is a Riskesdas. There's 2000 to 2010 and then until 2018. The last one is in 2018. Okay. Yeah, it is more technical. If you want to ask the data for them, you can access this website. Yeah. So litbang.kemkes.go.id, layanan permintaan data riset. So they already have how do you can ask, and then how many price that you have to provide maybe, but some not. Some are free, some are you have to pay per subset. Yeah. And then they already declare what is your purpose. You have to declare, is it for a research study, is it for a published article, is it for a program, is it for other project. Yeah, you have to declare to them, and then you send a letter, and then they declare that in 7 days they will be response, yeah, to you, and then they will send you either they could provide or not. And then of course the other administration process. Yeah, it means that it's not quite long time to get approval to ask your data. It's I think it's improving, because last time I see is about 2 weeks, yeah, 14 days, but now they are moving to 7 days. This is the publication that maybe we can do a kind of this for Indonesian population, because the sodium consumption, we have already data in the Riskesdas, and also the blood pressure. We can have the data in Riskesdas also. So we can do some kind of this research, but this one is in Japan. And also something of like this, because in the Riskesdas you can ask specific area, yeah, like province or a city or a high altitude region. Yeah, you can ask for you can ask for the mountainous area and or the seashore areas. It's up to you. Yeah, so this is prevalent hypertension, diabetes, and associated risk among geriatric population living in high altitude region. This is in India, but you can also do some kind of this research in Indonesia with the Riskesdas data. Maybe this is my latest group with the cardiologic department, because they will they have a hypertension group, and they will collect all the data in a Riskesdas and will make a cross. So, but the theme is here is urban and rural. So how to compare between urban and rural. But you can also do the comparison maybe between the ethnicity, the dominant ethnicity, like from West Sumatra, maybe you know, Padang people, they usually have some serious culture on a cuisine, on a culinary aspect. It's different than maybe some people from Jogja or other area. Yeah, so is it any correlation between the food they consumption and the cuisine they take over there with the pattern of the disease? Yeah, in this case is hypertension. So this is about the diet, and it's about the smoking and alcohol, and this one is about the mental situation, psychosocial and others. So there are some 7 group, I think. Yeah, so many. So this is for 1 student here, and then so you see that so many students could be accommodated in this kind of draft group research. The second one is also interesting is the Indonesian Family Life Survey. So this data provided by RAN Corporation in partner with Survey Matter Indonesia, and they do it already in five waves. In 5 waves in 2017, I believe. Yeah, 2017. So they claimed it is representative about 80% of Indonesian because they just left the Moluccas and the Papua. And because the Moluccas and the Papua, they have already the East Indonesian data set. So it's different data set. But here, most of Sumatra and I think South Kalimantan and then all Java, and then some Sulawesi. Yeah, it's about 30,000 individual. Yeah, 30,000 individual. So, and then it's 90% the same population since they do the first in 2000, I believe in 2000, around 2000, before 2010, I believe. So you can do the longitudinal research here because 90% of the respondent is the same. It's different than Riskesdas because Riskesdas is always cross-sectional design. So it's just one picture at a time. But in IFLS, you have the picture from time to time. But of course, the instrument is sometimes they do innovation in that. So maybe they get longer and longer. So the instrument for the 2 latest survey will be different with the previous research. But you can also have some additional in the newest research, newest survey. Okay, so this is some example for the menu in IFLS 5, and they open to analyze. Yeah, so you can have in education, and then the well-being in a social aspect, and then this is and the merit status, and then smoking habit, and then quality of life, chronic condition, psychological aspect, and others. Yeah, so sleep, cognitive capacity, insurance, and other things. Yeah, so food frequency and others. So many. Yeah, and it's open so many opportunity. Even though one of our colleagues in Gajah Mada said that there are some researcher, I think from Taiwan or where, he published about 11 publication a year just about IFLS only and Indonesian data. So yeah, like this. So the prevalence and social determinant of hypertension among adults in Indonesia. This is based on IFLS 5, and it's done by our colleagues from South Africa and from Thailand. So if you want to do also for Malaysia data, yeah, you can do also something like that. Okay. Then this one is done by our colleagues from dental department. Yeah. Bu Nino is about depression symptoms and recurrent upper stomatitis. Yeah, evidence from population-based study in Indonesia. So because she study about the oral medicine, so is it stomatitis is related to depression? Yeah. So and it's already in published in oral medicine. journal. Yeah. So even I will back here. Even the data is in 2007. Yeah, this is the IFLS in 2007, and it's published in 2020. So it is still okay to do the past data like this. Yeah, and this one is also by our colleagues in Pak Anies is in public health. I think from public health, from nutrition department. Yeah. Association between depressive symptoms and food insecurity among Indonesian adults. So this is from 2007 and 2014 Indonesian Family Life Survey. So this quite source data for you to use. Sorry, yeah, this one. And a little bit different is from the Bureau Pusat Statistik. Yeah, so the Statistic Bureau here, they also have some data, but it's quite pricey here. Maybe from for the government, or if you have some project and you can because they maybe since start from 2 or 3 million, something like that, but mostly more than 10 million, but they give you all the, it's quite big, yeah, more than 500 megabytes, yeah, data. It's quite big. They don't sell in pieces. Okay, yeah, but you can also go for the book, yeah. They provide the book from Sensus Penduduk, from they have publication, so you can also buy the book from their census, yeah, census or survey. Yeah, this one is one of a example from BPS data, yeah, BPS data, Biro Pusat Statistik, but they do the BPS data from East Java BPS. So there is also some. So the BPS is in central in Jakarta, and then also in province level, and also they have in a city, in a district level. So you can also do the district level or in a province level. So this is for Kusta, lepre, prevalence of lepre, and then they use spatial Darwin model. So how the distribution of the lepre disease in our province in East Java. And this is from our city, but of course it's the last is 2018, I think. Yeah, this is in Surabaya, Surabaya Bureau Statistik. This is you could just click it, and then they. I think this one is free. Yeah, it's much more in family planning data. Yeah, so many family planning data here. They have some specific here in Surabaya. So this the link is surabayakota.bps.go.id. Okay. Yeah, and the newest census just finished it in 2020. Yeah, 2020, and they already published the data. You can also use this as your base, or maybe you will access those certain age range. So they now divided the Z generation, the X generation, like me, and the millennial and the baby boomer. Maybe Prof. Nico, you are here, I believe. Yeah. And then the pre-boomer, yeah, was already before the pre-boomer maybe have experience in World War I or II, yeah. And then this is the composition of Indonesian generation according to the newest census in the 2020. So we have more than 270 million people now. Okay, oops, sorry. Yeah, the other opportunity is through the, I think, yeah, this one, the climate data, weather or climate data. We have could access the meteorology and geophysica, and they also could provide you the data in this link, yeah, data online bmkg.go.id home, and then how you could provide ask them for data. You can go to their portal, and then you has to register, and then you ask for the data, yeah, either Excel or PDF, and then you can do for your research. But they provide for 1 month parameter for rain, how much rain we have, the temperature, and the ambient humidity, and then the wind, yeah, the speed of wind, and also other thing, yeah. Also for the earthquake data, the magnitude of the earthquake, yeah. This is very popular in area of climate, is very influenced for the disease like dengue, yeah. So this one of my publication with the students is about the climate variability and dengue hemorrhagic fever in Surabaya, East Java. So it's based on the analysis of climatology data. Yeah. And in already published last January, I think, in Indian Journal Public Health. Yeah, and this, if you see in the PubMed, yeah, about climate and dengue transmission, the trend is like this, yeah. So many people using the climate data and then related with the burden of dengue or with some aspect of dengue. So it's 100 result about climate and dengue transmission. Okay, yeah. So this one another example about effect of local and regional climate fluctuation on dengue outbreak in southern Taiwan. Yeah, so we can have many aspect of climate, and now the climate is very much volatile because I don't know about the global warming or an other thing. Yeah, because now we have the rain is not quite in the schedule, and it's the density and the time is not quite like usual, yeah, something like that. Yeah, and also we can have the information about some quality air, some aspect of air quality. So like SO2 and O2 and ozone and particulate. Yeah, so here we can see that the Medan is on the borderline of green and blue. Yeah, so the green is a good and blue is a intermediate. Yeah, and yellow is already not good. Yeah, so Medan is already like this. And if you are in want to know about Pekanbaru in forest, what do you call it, forest fire season, yeah, maybe you can also check this website. The one the last it's the since 2014, yeah, Indonesia already have national insurance security, national insurance. National insurance, yeah. So national insurance, and they now provide the data also. Yeah, they now provide the data. So you can ask the data, the PCare data here with this prerequisite, and then they provide in 7 days also. But they said until 2016 here, but now they said until 2018. But I don't know, maybe we can ask for more recent if we have some with some letter or others, yeah. So they open the data from national insurance. It's a kind of disease and treatment, so many data here, I believe. Yeah, and they also, if you want to know what they have, you can download the book first. Yeah, you can download the book, buku sampel BPJS Kesehatan. It's until 2016. Oh, also for the data in BPS or data in Riskesdas, you can also download their report, so you know what the data available. What kind of data available for there? What the parameter what the statistic they measure? So this one is a morbidity pattern of chronic disease among Indonesian. Insight from Indonesian National Health Insurance data, sample data. So this kind of publication, and this recently, just December 2020, yeah, using that data. This one is interesting. If you have time, you can wandering around in this Gapminder.org Dollar Street, yeah, Dollar Street, founded by Anna Rosling and in Sweden, I believe, yeah. So this is the word in pardon me, the word and in one street according their income. So this is the poorest.
Dr. Puji?
Yeah.
Excuse me. We have 1 minute left.
Okay.
Could you please shorten your
yeah,
talk,
okay.
please? Thank you.
So from the poorest to the richest, and then you can see their situation here. Yeah, there are so many picture here. They use picture as a data. Picture here, maybe about 100 or 1,000. Yeah, thousand picture. Yeah, and you can also track for Indonesian only, like this. Yeah, this is for Indonesian only, but also you can ask for another country. Yeah, this is Indonesian only, and is the portrait is the family. You can also ask for another portrait like beds. Yeah, you can do this the bedroom situation. Yeah, and also other thing like toothpaste here. Yeah. Here is that we can see that one popular brand among the richest and the poorest is the same. Okay. Some ideas I could you can use is using the secondary dataset in isolation. If you want to reassessing a dataset with different research question in mind, so maybe you want to be categorized, or you want to see how frequency in some upper shortcut or below shortcut, something like that. Yeah. And then combining two secondary data set to see the comparing of the data, and combining secondary and primary data set to obtaining accessing information that inform your primary research. Yeah. And some ideas also, you can use Google Map for spatial and aggregate analysis on diseases, qualitative and quantitative analysis in YouTube, maybe for how education and COVID in YouTube. You can also do the analysis over there based on Gapminder picture, develop some health question for certain social class, combine some risk factor and make new regression model. Yeah. Yeah, of course, there are some disadvantages in this method. Yeah, data is not always available in the form or scale you need it, not updated and lag behind data. And maybe you need more appeal statistic analysis to make novel information. Yeah, and the data, of course, should be carefully interpreted and generalized because their assumption may be different from your assumption, and then how do you interpret it and generalize should be taken care of. Yeah, but you could collect longitudinal data, yeah, like that, and more behind desk work than field. Of course, this is important in pandemic because we don't need to go somewhere that maybe some risk over there. Yeah, unless using medical record, the data is completely and robustly anonymized. Yeah, no ethical clearance needed. I mean, because they already do their ethical aspect, so we don't need to do that anymore. I mean, the data collector, I mean, the provider already do the ethical aspect. Yeah, so practical algorithm here, you can look around what the available data and find some useful idea, and then apply for the data and follow the procedure and wait and do the analysis and try to extract novel and useful information. Yeah. Write a fruitful discussion and draw a useful conclusion. I think that's all. This, if you want to, yeah. Thank you.
Thank you, Dr. Puji. It's very interesting that secondary data are available in our country, and it is, I think, of good quality because professionals conducted that survey and also census.
Yeah.
Yeah, but for COVID, it is challenging because some colleagues have concern about that because the data are not uniform, so we cannot create a big data with the same platform. Okay, all right, thank you. The next session is for discussion. I would like to invite our panelists, Dr. Muhammad Miftah Suhurul. This is our vice rector or vice president of Universitas Airlangga. He is a prolific writer, and in the past, he also awarded by Role Employee of the Year, and he is now the vice rector, the vice president for internationalization, digitalization, and
information.
Thank you. Yeah, it's quite new for us because this is not the usual term that we use in the past. The second panelist is Dr. Pirlina, Magister Kesehatan. Yeah. She sits beside me. She worked in our Department of Public Health and Preventive Medicine. Also, she went to Botswana to get her diploma in population degree, and yeah, she also get the diploma from the University of Washington. Oh, Dr. Muhammad Miftah Surur is internist and subspecialized in. He is a consultant in gastroenterology and hepatology. So, Dr. Miftah, please comment or ask or discuss the presentation today.
Thank you very much. Thank you very much. Professor Nicole Nakelker, thank you very much for your lecture. It's very interesting, and also I'm very happy that all our lecturer in here could receive your lecture about the research in and on the COVID-19 pandemic. I'm very interesting that you mentioned several methods that we know you are very famous biostatistic area, and what I'm very interesting about Zealand's design. That in the clinical trial, actually, Zealand design recently in randomized control trial is still in debates and controversies. And we know that the Zealand design in the principle is the participants are randomly allocated prior to seeking consent, and then these participants allocated to the intervention group are then approached and offer the intervention, and which they can decline or accept. For your opinion, is it still relevant, the Zealand design we can do in our city? It is my first question. And the second one, what is the strength or opportunity of the Zealand design in the COVID pandemic time? Probably you have idea or discuss about the practical of Zealand design in your university. And I also very happy that the Associate Professor Puji Lestari is very experienced to do the secondary data studies. However, I try several times to do try to write the secondary data studies. However, I have several problems, including probably some of the my idealist value could not accept with all the data. For example, if I want to analyze the variable A and B, sometimes I know several variables influence this association. Therefore, different with the primary data that I can manage, or I can make a design. The secondary data have very big weakness for my opinion. And the second one, probably I also do not have many ability to do statistics for big data. We know that usually secondary data for Respiratory or IFLS usually use have a very big data that usually have to do by Stata, not SPSS or other popular statistic. How do you have the tips for my problem? Thank you very much.
Thank you. Professor Nico. Professor, sorry, Professor Nagelkerke, probably. Would you please answer the question? Please unmute your microphone.
Sorry. Thank you very much. Thank you very much for the question. It's very nice that you raised the issue of Zealand designs. I think they have been underutilized. I mean, they were developed by Marvin Zealand a long time ago, and they have been around for a long time, but never really very utilized to their full potential. One of the limitations, of course, is that if you want to take a random sample, then the control group basically becomes the rest of the population from which you sampled, and it's generally considered unethical to collect more information on that group than standard information. And that is one of the limitations. So if you want to study the effect of some kind of novel DNA test or whatever that you need in both groups, and that is not standard, then this is generally considered unethical to go to the control group and to say, okay, well, we measured something extra, not the standard things, and that is a limitation. But nowadays, more and more things are collected more or less standard in all patients. So this becomes less of an issue, I think, generally. And therefore, and it's also the speed by which you can do a Zelen design that makes them very suitable for a situation like this pandemic, in which you want to evaluate lots and lots of different treatments and discard them when they are not promising. That makes them especially very suitable. That's my opinion. But I think it's up to you to promote them in Indonesia. I think you could be, you could show the full potential, and I would love to see you doing it.
Yes.
That would be wonderful.
Thank you, Professor Nico. May I ask you one question more? That do you have tips to prevent the bias during the consent and also recruitment of the process of the subject? We know this is the main problem of Zealand designs. Do you have? I mean that is there any new modifications that we could reduce the bias? Thank you.
Well, they don't, then it doesn't need to be a bias. I mean, if you probably record the population from which you sample the group that you're going to offer the treatment, then there doesn't need to be a sample. Of course, if most of the people you offer a treatment are going to refuse, then the whole thing will be so biased that it's not possible to use this design. That's also a limitation. But if, say, 70, 80, 90% of the people you offer the treatment, and of course, again, it depends on your skills of explaining this to the patients, then I think you can use it safely, and it will be just as effective as a standard randomized clinical trial. And of course, one doesn't exclude the other. I mean, you could do quick Zelen designs, and then the few treatments that come out as very useful and promising, you can then design a standard randomized clinical trial to study them further. And that it was more efficient than doing hundreds of randomized clinical trials on all potential treatments and interventions. That's my opinion, but I mean, depends on the circumstances. Thank you very much.
Thank you, Professor Nico.
Thank you, Dr. Puji, about the application for big data.
Yeah, first, maybe the questions is about how to control the confounding variable. Yeah, I mean, if A then B, so what else? You don't know in that data what is condition of A and what is condition of B. So of course, like in primary data, you have to include your confounding variable. You have to ask also your confounding variable, so you can justify by that. I mean, or you make some inclusion criteria. Yeah, so maybe you have maybe 1,000 data, but and then after you apply your inclusion criteria, you can also omit some is not qualified or maybe not in your inclusion criteria. So you come up with more homogeneous and more acceptable for your variable you measure. So you can have some, yeah, a little bit more clean interaction, something like that. And then for data, yeah, for a big data, I think if you have some specific questions, I think you won't deal with a big one. I mean, it's about thousands. It's about thousands. So 1,000 is a deal. SPSS is okay. So SPSS is until 1 million, I believe. But yeah, it will takes time, for a longer time only if you run the analysis. But it's capable, no problem for that. Yeah. And then maybe Excel is more limited. Excel is maybe when 10,000 or something. Yeah, 10,000 or something. But I think the SPSS or it's okay enough. Stata is actually okay, but you have to remember the comment and something like that. Yeah, it's need more refreshing and need more programming capacity a little bit. But actually, EFLS data is in Stata, but you can export it and then use it and analyze it in SPSS on no problem, something like that. So yeah.
Thank you, Dr. Fuji.
Thank you. Thank you.
The second panelist would ask about something that I would like to ask for your patience for the three the three people that from the audience that, we read your question, but please be patient first because the second panelist would like to ask some questions. Thank you.
Assalamualaikum. Good evening, Prof. Nico.
Good
Thank
evening.
you for coming. Yeah, I'm
Good morning.
delighted to be a panelist on this webinar. I'm very interested in looking at the graph of your polygon frequency. I see levels, trends, and pattern as follows. The level of that is higher than the pre-pandemic era, right? The trend
Sorry?
is fluctuate. The level of death is higher than the pre-pandemic era, right?
The level of what?
The trend is fluctuated, increase, then drop, yeah, in the latest. The pattern is somewhat like a skew to the left curve up to now. Otherwise, it will follow a normal distribution curve along with time. And second peak around September, as you mentioned. So could you tell us more about this figure in terms of level, trends, and pattern, please? Thank you.
Well, I stole this picture from a preprint in one of those archives. So as a thief, I'm not really responsible for what I have stolen. I just was very opportunistic. This is, but I found it very interesting. And when I saw it, I thought this is a wonderful idea. I always admire inventive ideas when people come up with a simple idea of measuring something that seems very hard to measure, and the idea of going to the number of permits for burials seem to be very, very interesting and very kind of genius that I really admire. What really causes all those peaks, I don't know. I mean, it's in Europe, and we see also a second peak around September, and that occurred all over Europe, and there's
technical
only
difficulty.
one. Sorry.
Yep.
And there's actually, in my opinion, only one explanation is that then schools reopened. I mean, the weather was still warm and nice, and people could still go out and ventilate their rooms because it wasn't cold yet in September in most of Europe. And the fact that all over Europe, the numbers went up, and especially in younger age groups, had only one explanation, that schools play a major role in driving the epidemic. And it's, of course, it's logical. I mean, you put people together in small classrooms, and they play with each other, and they pull each other, and they talk to each other, and shout at each other. And of course, a lot of transmission must go on. And since a lot of children are infectious without being ill or being very ill, this is the ideal circumstances for transmission. But I don't know what it is like in Indonesia. It could be very different. People behave differently, perhaps. I'm suppose that in Indonesia, children are more well behaved than in Holland. So it may be that it's very different in here, but it's definitely a topic for study. It seems that there's also a peak here in September, but not as large as occurred in Europe. So interesting.
Thank you so much.
Thank you. Any question for Dr. Puji? No?
Not yet.
Okay.
Thank you.
Thank you. Now I would like to open question from, the first question is from Dr. Yudi Wibowo. In Indonesia, this is for Professor Nico. In Indonesia, currently implementing micro lockdown. What things can be researched at the community level related to this? Is it sufficient to make the diagnosis only by means of rapid antigen examination? Regarding the SIR model being the simplest model, is it still relevant to research only based on the SIR model if there are vaccine intervention and others?
I think the SRR model is a kind of starting point. I mean, it's clear that if you use a simple SIR model, then the predictions are completely irrelevant. I mean, they don't predict accurately. The SIR model predicts a peak. What is useful for such a model is to see, okay, what explains the difference between the simple SIR model and what we actually observe? Why is the epidemic more stretched out? What is really happening? Are people getting more socially isolated, etc.? These are all questions you can ask. And then you could, of course, adapt your model and take, so, okay, let's start with an SIR model, but then bring in social stratifications, add in contact structures like schools, household structures, and all kinds of different aspects, and see whether those aspects actually explain the difference between the simple model and what is actually observed in terms of mortality and morbidity. And that's the way you can develop a more comprehensive model and thereby understanding of what really goes on in the actual epidemic or pandemic.
For the second question, could you read it?
No, I didn't. What is it?
Oh, this from Daniel. I'm in the field of anatomy. I'm interested in researching COVID-19 course.
COVID-19?
Corpse, the body of a dead body, corpse.
Oh, corpses, yes.
Corpses, yeah.
Yes. That's interesting, yes. But then you have to, how that is very ethical thing. I mean, how do you want to examine corpses of people who died in hospital? Or that's probably the easiest. Then you have to, but you, of course, you have to contact their next of kin in addition to the hospital, and see whether they allow that, because you want to do an autopsy, I presume.
Yeah, I think I could edit some insight for Dr. Daniel, Dr. Sam, if you allow me.
Yes, sure, please.
Yeah, so for corpses, of course, you have to contact your college or maybe yourself in a forensic department, because the one who deal with corpse body of COVID-19 is a forensic department, and then you have to ask the permission, the informed consent from the family. Yeah, maybe that's the one will be tricky, because maybe Prof. Nico, if you are aware here, people have some prejudice of the one everybody will be died of COVID in hospital, something like that. So they kind of don't like or have a prejudice that they will do something in with the corpse. So yeah, but that's the tricky part. But if you want to, it's not impossible, I think. But you could still access the corpse of COVID-19, and it will be a very valuable information if you could do it. So I encourage it if you want. Thank you.
Thank you. The third question probably is because this is about Posyandu and also Kader volunteers. What are your opinion regarding self-report data?
Please unmute.
To who is asking who to whom?
Oh, Ronald, both of you actually, but this is our localities. South Posyandu is introduced in Indonesia, and also Kader as volunteers. So I would like to ask Dr. Puji first.
Yeah. Okay. So I think for self-report data is no problem. Yeah, I mean you can use it also, but of course you have to mention it in your methodology. Yeah, because sometimes sometimes people ask their friend to do the report for them. So sometimes you have to see where it's come from. I mean, the Google form sometimes, if you ask for a certain number of phone number, or you have to check, and the Google form should be more in detail if you want to. But it's okay to use it with all the constraint, of course, and you interpret it with that situation, but it's still acceptable. Thank you.
Thank you, Dr. Puji. Prof. Nico probably would
I
like to add
fully
something
agree.
for
I
this
mean,
self-report.
there's nothing to add. I mean, this is perfect answer, yeah, from Dr. Puji. So I fully agree.
Thank you.
Thank you then. All right, so to sum up, I would like to take notes from your discussion. So basically we can do, whether it is a primary data, we can do research with primary data with of course, with precautions. And also the secondary data also has the plus aspects. Yeah. Also, there are some challenges in COVID-19 data, and some of our colleagues are working on that. So how to integrate data from the hospital data goes to CT data, data at city levels, and then public health office, and also it as in the provincial. Yeah, they are not uniform, so it is quite challenging. I think we have this fruitful discussion. This for us to conduct research in the pandemic era. Thank you. I would like to hand this floor to the host, Dr. Kartika. Thank you all.
Yeah.
Thank you for spending time with.
Thank you.
Thank you.
So thank you very much for what a great discussion from our moderator, also all speakers and also all panelists. Thank you for your enlightening discussion and sharing. So thank you also for all the participants that is actively participate in this webinar. So now we all now reaching the end of this webinar. So for the all participants, the certificate will be sent to your email with the guidance as mentioned from the AWCS committee previously. And also, once again, thank you for joining our webinar today. We do hope you always be in the good health and stay safe. My name is Kartika Frida. I'm sorry for the if any inconvenience happens in today's webinar. We hope you had a great time with us. Thank you very much.
Thank you very much.
See
Thank you.
ya. Waalaikumsalam.
Fakultas kedokteran, Unai tercinta, jadi kebanggaan Indonesia. Pelopor pengembangan pengetahuan, inovasi, adaptif kolaborasi.
Kita mencintai, Irga Unair hati kan empati, pusat pendidikan terkemuka, world class medicine faculty. Fakultas kedokteran, Unair tercinta, jiwa wirausaha, akhlak mulia, profesional responsif, inovatif, modern dan bangun entrepreneurship. Kita mencintai, kita Unair hati kan empati, tanggung jawab disiplinkan diri, the prime medicine faculty. Kita Unair, kita mencintai, kita Unair hati kan empati, tanggung jawab disiplinkan diri, the prime medicine faculty. The prime medicine faculty.
Oke, boleh live ya.